And we will finish off our terrific year in review with Dr. Iverson, who actually has an interesting background. She actually completed an IM residency and subsequently completed a fellowship in both pulmonology and critical care. And then she figured out that she's going to go to a better side of the world in the hospital and became an anesthesiologist as well. And she's currently working at an academic center doing both general OR cases and ICU medicine, and is actively engaged in medical student and resident and fellow training. She will be speaking to us regarding updates in critical care anesthesiology. Please welcome me in joining Dr. Iverson.
My disclosures are nothing remotely relevant and not even financially beneficial. There are some new CPR guidelines coming out. We're going to briefly talk about what's currently existing, but what you know algorithmic-wise is likely to change next month in October. We're going to talk about new ARDS guidelines and definitions, and then what I think is actually the most pertinent thing to you is that there are now new AMI and PCS or ACS guidelines that will affect us perioperatively. So just some background information. The way that the AHA currently gets or makes up its CPR guidelines or its BLS guidelines is it takes its cue from an international committee, ILCOR. This committee is made up of people from different countries, and they meet about every 5 years, and then this committee gives its recommendations to agencies like AHA in the United States and other things comparable. And from that, the AHA then comes out with the new guidelines that we're familiar with. This is based solely off of observational data. So one of the first changes it made is for out-of-hospital cardiac arrest with EMS providers. They are now recommending that EMS providers bypass facilities that are smaller facilities if they do not have what they call like cardiac arrest centers or critical care capabilities 24/7. This includes cath lab interventions 24/7. It includes a neurologist, either physically there or presumably by telemed. This center should be mechanical ventilation capable, so they should have an ICU. And then ECMO capable we'll come back to. But I say this because for those of you that are in smaller, more community rural hospitals, it may be that you end up not seeing as many of these because some of your EMS agencies are bypassing you historically. CPR boards or back boards. The recommendation is really to not delay CPR to get a board. Any hard surface will do, and all of the hospital beds actually have a CPR bed mode. If you push it, it just takes the cushion out of the bed and it just becomes a rock hard surface. And just note that this is actually from mannequin testing. There's no human data at all for this. For those of you that do pediatrics, in the event for whatever reason you have a kid that is in cardiac arrest, if you have a table, some other hard surface, that works just as well. If and when you achieve ROSC, your goal vitals are as follows. You ideally want a blood pressure that is perfusing end organs, so a map of 60-65. We heard yesterday a little bit about hyperoxia and how we'd like to avoid that, so your goal stat should be in the mid to low 90s. PaO2 is about 75 to 100. Avoiding hypo and hypercapnia, ideally, recognizing that post-arrest, these people are going to have some sort of a respiratory acidosis component you'll have to offset. And just avoiding fever or hyperthermia. We are no longer cooling these patients. In December of 23, AHA actually issued a focused update saying that regardless of your patient's GCS, regardless of their presenting rhythm, whether it was shockable or not, we are not cooling these patients anymore. The goal is just to avoid fever or hyperthermia pretty aggressively if needed. EEGs and AEDs. AEDs are anti-epileptic drugs. There is no need or no guideline for routine EEGs in patients unless you feel like it's imperative or if you think that there's a clinical suspicion that your patient is having a seizure. If you see things like myoclonic jerks and you want to know if it's a seizure versus not, by all means get an EEG, but you don't need it just because your patient's post-arrest. and there is no need for routine seizure prophylaxis in these patients. That said, if you get an EEG and it is abnormal, then go ahead and treat them with anti-epileptic drugs, even if there's not something that looks epileptiform. If it's read as an abnormality on the ictal intra-ictal spectrum, go ahead and treat it, and that is a new recommendation. With regard to ECMO, I do work at an ECMO center, realizing that often very large tertiary centers that are capable of dealing with these patients post-arrest may not have ECMO capabilities. Your EMS providers don't need to come to me if there is a hospital closer to them that can handle everything else. That said, if you are at a center where ECMO is capable, there are weak recommendations for consideration of ECMO, not necessarily cannulation. So patient selection is key here. This is based off of 4 randomized trials, very limited patient population, all had shockable rhythms. We know often our patients are not shockable, or at least when they are identified, they're PEA or asystolic. All of these studies were underpowered, and really it was kind of a wash. 1 showed benefit, 2 didn't, 1 suggested a benefit, but never reached significance. Pregnant cardiac arrest patients, there was no change to the guidelines. Essentially, if you have a patient who presents in cardiac arrest and she is obviously pregnant, even if you don't know the gestational age, you can assume it to be in the latter half or the second half of gestation. That is an indication for an immediate section. Don't worry about how far along mommy is. If mommy looks pregnant, just do the section. Of note, the survival actually is increased if pregnant patients undergo ECMO cannulation or eCPR in the event of something that is reversible and catastrophic. So if there's LAST or an AFE, that sort of thing, ECMO actually has a higher survivability in this patient population. Presumably, if you are at a place where you have a catastrophic situation like this, if you still have ongoing cardiac arrest or hemodynamic instability, I would push for trying to transfer them sooner rather than later. We're going to see if this little video actually plays, but the CPR feedback devices are now weekly recommended, both for rate of compression as well as for depth of compression. And in particular, I highlighted this because these are now showing up on certain defibs. And so take a look the next time you happen to have a patient in cardiac arrest, whether your monitor is or is not yet utilizing this. Ours, for example, are not yet utilizing this, and I know this because the pads that have the feedback capabilities are not pads that we're using yet. This is a new one, maybe a little controversial depending on your thoughts, but recommendation for consideration of organ donation. This is a new recommendation. And what this means is if you have a patient who has evidence of neurological death, so brain death, what we would normally call death, or if you have a situation where you've achieved ROSC, but the patient, for whatever reason, is not going to neurologically make a meaningful recovery, or family feels that otherwise the patient would not want to continue in this course. If you have a patient's family that is considering just changing gears and focusing on more comfort, there is now a push for consideration of organ donation. And we did hear about how organs are in short supply. Other potential changes coming in the future, there is potentially a thought that we may change terminology from CPR to CCR, which is cardiocerebral resuscitation, with less emphasis on pulmonary and more emphasis on heart and brain perfusion. Less CPR interruptions, we've been pushing for a long time, less time off of the chest, but now this is going to come in the form potentially of things like oral pharyngeal airways or supraglottic devices, and so your patients may not arrive to the ER intubated. Again, there are new AHA algorithms that are anticipated to come to fruition next month, so end of April. AHA is going to meet with the international committee. Potentially new guidelines are going to come out. And then from October until March of next year, the AHA is going to spend time teaching the people who certify us or recertify us. And so we may not actually see those algorithmic changes, if there are some, until early next year. And now I'm going to see if this actually works. Okay. This is just an example of what it may look like, and this is a two-rescuer CPR from an EMS standpoint.
In this simulation, an adult has suddenly collapsed and is not breathing normally. There is no bystander CPR being performed upon EMS arrival.
He's not breathing, Pete.
Okay. You're going to start compressions. I'll get them on.
The emergency medical providers quickly establish unresponsiveness and that the victim is not breathing normally. Remember, gasping is not normal breathing and usually represents cardiac arrest in an adult. In this two-rescuer scenario, Rescuer 1 starts chest compressions immediately without delay, ideally within 10 seconds of arrival.
All right, so we're going to start 2 minutes now.
Simultaneously, Rescuer 2 places an oral pharyngeal airway with high flow oxygen, preps for an IV or intraosseous line, whichever is faster, and prepares to take over compressions and prepares to defibrillate if indicated.
And so the point of that was to show you that time off of the chest was key. Walking in immediately, you don't need to necessarily do the whole 10-second pulse check. If you don't hear anything, feel anything, see anything, and your patient clinically has cardiac arrest, call for help, get somebody to get an AED and start CPR. But time off of the chest is key. And then the second rescuer had an oral airway and a non-rebreather that they just put on. And we heard yesterday a little bit about apneic oxygenation. Okay. Changing gears, moving into ARDS changes. In the United States, the ATS, or the American Thoracic Society, is sort of the governing body with regards to ARDS. There are European guidelines as well by the ESICM. These two converge on several different things, and then they diverge on several different topics as well. Current definition of ARDS is that it is an acute onset occurring within 1 week. You have to have bilateral infiltrates on imaging. So historically, this is going to be something that looks like pulmonary edema, but this is not going to be something that's attributed to cardiogenic pulmonary edema nor volume overload. So not the dialysis patient that is non-compliant with their sessions, not the person whose EF is single digit in the setting of an MI. P to F ratio less than or equal to 300 and a PEEP greater than or equal to 5 centimeters. There are new proposed definitions that now include some of the other things that we talked about. Yesterday we heard a really great lecture about the benefits of high flow nasal cannula. In my center as well, we use OptiFlow, but as you heard, there are different brands. Part of the reason that we've now incorporated this is that in certain patient populations, especially after COVID, this is becoming more and more something that we see in the ICU settings. And so having a minimum liter flow of about 30 liters or more, we heard yesterday you could actually go up to 70 liters. Some of these will actually go up to 100 liters. Using a P to F less than 300, or a SAT to FiO2 ratio less than 315, because sometimes you don't have an arterial line or an ABG, or a pulse ox less than 97%. Additionally, they are opting to keep the bilateral infiltrates on imaging, but they are now recommending the inclusion of ultrasound, okay? So if ultrasound is an imaging modality that you're comfortable with, and UCB lines, which goes with an interstitial process, by all means. In settings or countries that are resource limited, they're not requiring the use of PEEP. Not every place has PEEP as an option. They're not requiring specific O2 flow rates, nor are they requiring specific respiratory devices. There are consensus guidelines to maintain low tidal volume ventilation and low peak inspiratory pressures. Tidal volumes should be 4 to 6 mLs per kilo of ideal body weight, though if needed, you can extend up to 8 mLs per kilo if your patient has hypercapnia and acidosis that you are not able to offset with increasing minute ventilation by respiratory rate. Plateau pressures, again, remaining less than 30. ARDS consensus is for proning, still exists, though ATS now says proning at least for 12 hours, whereas European guidelines are saying for 16. The use of VV ECMO should be considered in patients who have severe hypoxemia or hypercapnia that is non-responsive to your ventilator changes and proning. It's a conditional recommendation. Again, patient selection is going to be key. They are not recommending against any high pressure recruitment maneuvers, nor are we recommending against any high frequency oscillatory maneuvers. And again, we're avoiding barotrauma, volutrauma, that sort of thing, atelectrauma. What about steroids and ARDS? So ARDS is a pretty heterogeneous process, and some patient populations have a very exaggerated inflammatory immune response. We don't know who these people are. We have not been able to isolate the particular lab that will identify this person is steroid responsive and that person is not. Some people have inflammatory markers that are very high and they don't respond to steroids. Others don't have elevations in inflammatory markers and they do. And so it's very difficult to decide whether we do or don't treat with steroids. The most common cause of ARDS is pneumonia, and with the exception of influenza pneumonia, there is a mortality benefit in patients that have a pneumonia that is community acquired, whether it's community acquired that's bacterial or whether it's COVID. And so the European guidelines actually just chose to ignore it. They don't comment on the use of steroids at all. No recs for it, no recs against it. Whatever you do is what you do. ATS has a new guideline that is conditionally recommending the use of steroids. And again, this is based off of several RCTs that show that there is a benefit for severe community-acquired pneumonia, again, not influenza. Steroids are indicated in those ARDS patients that are severe, who are intubated, or those that are non-intubated with community-acquired pneumonia or COVID. Don't start steroids if your ARDS is in a prolonged phase. So if you're 2 weeks out and those patients are coming to me for ongoing management, I'm not likely to start steroids. There's no specific regimen that was recommended. It's just, hey, think about this, whatever you feel like is appropriate. Neuromuscular blockade, ATS still has a conditional recommendation if your P to F is less than 100. Early on, so in the first 48 hours, again, in conjunction with low tidal volume ventilation and proning. European guidelines actually have moved away from this. Several of their studies did not show benefit, and they no longer recommend this. High PEEP versus low PEEP has always been the debate. If you are familiar with the ARDSNet trial, then this table is fairly familiar to you. The ATS actually is recommending a higher PEEP strategy versus a lower PEEP strategy, and that is for moderate to severe ARDS with a P to F less than 200. It's based off of multiple meta-analyses from 18 RCTs. And the Cliff Note version was that higher PEEP is associated with lower mortality, and this may be related to the driving pressure, though a lot of these RCTs came about before we knew about driving pressure, and as such, it did not specify. European guidelines actually have insufficient evidence to use low PEEP versus high PEEP, so whatever you're comfortable using is what you're comfortable using. For those people who may not be familiar, driving pressure is just defined as the difference between your plateau pressure and your PEEP. Ideally, the lower the number, the better your patient is going to do. When your driving pressure gets to about 14 and higher, your mortality actually goes up. So if your PEEP is at 5 and your plateau pressure is at 20, that's a difference of about 15. That patient has a higher mortality. If your plateau pressure is at 20, but you've raised your PEEP from 5 to 10, that driving pressure is now 10, and so it's associated with increased survival. This is the part that I think may be a little more beneficial to those of you at least who practice adult medicine. These are new ACS and AMI guidelines that came out early this spring. Just in summary, for acute coronary syndrome in patients with a low risk of bleeding, so the John or Jane Doe who comes in off of the street doesn't have a history of a GI bleed or other reasons to worry about GI bleeding. If they have an MI and they have intervention, we're now recommending that they have DAPT, just like before, with aspirin and your P2Y12 inhibitor, prasugrel, clopidogrel, ticagrelor. However, the prasugrel and the ticagrelor are more potent than the clopidogrel. So those are favored now over the clopidogrel. So you may not see as much Plavix. As a matter of fact, in the coming years, you probably won't see Plavix or clopidogrel as often. If your patient has a high risk of bleeding and has an MI, they're going to have DAPT for 1 month. And then after that 1 month, the aspirin is going to stop. And so they're only going to be on monotherapy, and it's going to be ticagrelor. And again, it is more potent than clopidogrel. So if you have to pick one, they're opting for something that is more platelet inhibiting and more potent. In addition, your patient should be on a PPI. If your patient has indications for oral anticoagulation therapy plus these antiplatelet agents, so for example, if your patient has AFib, maybe they've had a prior stroke or their CHA2DS2-VASc is high, perhaps they have recurrent PEs, DVTs, for whatever reason they have to have oral anticoagulation, they're going to take that G2 or that P2Y12 inhibitor after their MI, and ideally in this case it is going to be clopidogrel. So you're at increased risk of bleeding, so they're going to still use the clopidogrel for platelet inhibition. They're not going to go with the more potent one. Additionally, newly, they can now stop aspirin anywhere from 1 to 4 weeks. And so what this means for you is if your patient comes into the hospital with an MI, maybe they have a STEMI, and they're already on apixaban for whatever reason, they'll end up on apixaban and clopidogrel and aspirin for the first week, and then after a week or two, the aspirin is going to go away, which is new for us. And so again, you may not see people that are on aspirin in the setting of a STEMI, even with PCI. Lipid management, the goals are unchanged. High intensity statin is still the mainstay. However, if your patient hits the door and he or she is already on a statin therapy, or in quick follow-up after hospital discharge, their LDLs are not at goal, we're no longer allowing or waiting for patients to make dietary modifications and lifestyle changes. We're going to add on another agent from a different class. I put a couple of these up here. I think this one may be the pointer. I put a couple of these up here just so you're aware that they are injectable medications. They're well tolerated, and they're just twice a month. It's once every 14 days, and so these patients will take these at home. There's actually a new class of drug, and there only is one right now in its class, but they would continue these indefinitely. STEMI versus NSTEMI. Historically, we would differentiate if a patient came in the door with chest pain and they had a STEMI, they immediately went to cath lab. We didn't bother with troponins. They just did not pass go, did not collect $200. We parsed out the NSTEMI and the unstable angina group. They may get a cath lab admission, but they would be started on things like a heparin drip, and they would, we would trend their troponins and follow enzymes, et cetera. We're no longer doing that. If they hit the door and they're complaining of chest pain, if you see a STEMI, they go to the cath lab. They hit the door, they're complaining of chest pain, and their troponin is high, they're having an MI. They go to the cath lab. We're no longer teasing that out. And the reason is complete revascularization immediately has long-term benefits as opposed to waiting. Additionally and newly, both the culprit lesion that they see and very stenotic non-culprit lesions should be intervened upon at the same time. So if your patient comes in the door with an inferior STEMI, something in 2-3 and AVF, but there is maybe a circumflex lesion as well, or a distal LAD lesion as well, that is going to get intervened upon at the same time, even though it did not on EKG have associated changes with it. If for whatever reason your patient has multi-vessel disease, then they're just going to proceed with CABG. The caveat or the one exception to that is the world that I live in the CVICU. If your patient hits the door and he or she has cardiogenic shock associated with their MI, we are only going to stent the culprit lesion right then and there. We're going to get them through that cardiogenic shock period because going after the non-culprit lesions actually is associated with an increased risk of death and complications like renal failure, needing dialysis. But the goal is to get those non-problematic lesions prior to discharge. And then as we've been doing and many have been doing, they've now said mechanical cardiac support or circulatory support is reasonable for patients who have ongoing cardiogenic shock. These are my references. Any questions? Sorry, I know it was very fast.
Thank you, everyone. And I will now invite all the speakers back to the stage, and we'll just have a brief Q&A session so we can all make it to the airport. And in the meantime, I do have a question for Dr. Hufnagel. I haven't done OB for a long while. I don't even remember when I did my last OB case. Why not do the tubal during the C-section? Why come back afterwards?
They do. I'm talking about a postpartum tubal after a vaginal delivery. Absolutely, they do a tubal if they can get to the tubes when they do the C-section. But this is reactivation of an epidural that they had for labor or a de novo spinal after they've had a vaginal delivery.
I see. And then when it comes to the epidurals that have failed, do they have no level whatsoever, or is it just patchy, or like what have they found in those studies?
Well, their criteria in the study I talked about had criteria, but they would have already dosed those epidurals up and then found out when they were in the back that they needed more supplementation, which is why their strong recommendation is to really check and make sure that your level is good before you start. You can't always tell that, but if you have a block that doesn't seem to be getting up and it's patchy during labor, I would not use that for a postpartum tubal ligation. I would just wait till that wore off and do a de novo spinal. It depends on what your institution is comfortable with, because some places won't even do immediate postpartum tubals. We have agreed to do immediate postpartum tubals with a regional, and we're not intentionally going to do a general 1 hour after the person delivered because we allow clear liquids in labor. We're going to wait a little bit on that if they don't agree to a regional. But it's up to you whether you feel comfortable inducing a general right after someone just took a big long drink after they delivered. But bottom line is that do everything you can to tell whether your epidural is working before you even go back. So we start dosing our epidurals that are for labor for a tubal before we even hit the OR. Not 100%, but we give at least maybe 10 cc's of 2% lidocaine and see that we have a block that's coming on with a motor block and is coming up for the tubal before we get back there and waste everybody's time being back there and then have to try to figure out what we're supposed to do.
Great. And Dr. Gallagher, have you changed your practice to 1 hour? Have you had any?
I've not. My department has not officially changed our practice, though we have found in situations where we would otherwise have delayed in the last 6 months or so, we've been proceeding and found very little issue.
Very good. Dr. Wenzel, can you remind us the dose and the volume of the local anesthetic that you use for the sphenopalatine?
5 cc's on each side, and that can be either 0.5% Ropier Bupi alone or reduce that to 4 cc's and do a cc of dexamethasone.
Very good.
Yeah, so people feel like a little, some transient pressure and fullness, but it's not too painful and the volume is very reasonable.
Dr. Iverson, so you've mentioned quite a bit about the STEMI and NSTEMI, and my cardiology group is not very active, honestly, when it comes to cathing. They try to come up with all the reasons not to do it. How about NSTEMIs post-operatively or inpatient? Does that differ in the most recent recommendations that you've reviewed?
Yeah, so for us, you know, if they have an MI inpatient, cardiology is automatically consulted. As soon as you call for, at my facility, as soon as you call for a stat EKG, there's a we use paramedics, and there's a paramedic who stands there and essentially does a prelim interpretation. And if there's concern for a STEMI or a new left bundle, cardiology is automatically contacted. If that inpatient has other issues for whatever reason that would preclude a cath, then presumably they would be managed medically. I'm not familiar with that because I don't work outside of the ICU in that arena. That said, in our institution, if they need a cath, they get a cath. I have not seen the trickle-down effects yet of the NSTEMI going as far and as fast to the cath lab. Like most people, I find it's very proceduralist dependent. You know, some will do it with no problem, and then others it's much harder.
And for the new CPR guidelines, the thing about the LMAs and the oral airways, will that also include inpatient arrests?
I don't know, because those have not formally come down. I'm curious to see what, if any, algorithmic changes things look like in the next month. That said, our institution is very busy. We're a large level 1 trauma, and our EMS service has pretty liberal guidelines as far as pre-hospital care, but they will not, and we don't allow them to delay on scene to get an airway. So not uncommonly, they'll bring in a traumatic arrest with an eye gel in place. Again, because time is tissue, the goal is to get to your definitive place.
Dr. Washak, do you know anything about the MARS for liver transplantation or treatment before? Like, what's the most recent data on that?
So actually, it's funny. I feel like it was used. So I'll be honest. I don't know too terribly much about it, but when I was a resident in the ICU, it felt like every so often someone would be put on Mars. But it seems that as of recently, they're using it less and less. And I don't know if at our institution maybe they're just listing people quicker. And then, the hope that they get a liver quicker as opposed to just trying to stabilize Mars. So in my limited opinion, I feel like we've been using it much less.
And then, Dr. Deepti, how about leadless pacemakers? Do you have leadless pacemakers, the ones that don't have any wiring in there? Is there any specific new guidelines to how to manage those in particular?
That actually I did not come across. The guidelines I showed were 2024 AHA. It did not mention any leadless pacemakers. I'm not 100% sure. Anyone else knows that? If you come across that in ICU more.
We interrogate all pacemakers unless they've recently been interrogated, and depending on what the surgery is, what the site is, we don't treat the leadless pacemakers any different than the others. If I need to switch them to an asynchronous mode, we do.
Any other questions? There you go, sir.
Yes. What is the feeling on breast milk? Is that considered a clear?
And everything sort of we addressed. I'm trying to remember now in some of the European societies, I think there might have been slight changes, but this was solely focused on just clear liquids. So breast milk still 4, formula still 6. There was no consideration for changes there.
Enjoyed everybody's presentation. One of the for Dr. Harshvardhana, the implantables. There's so many implantables now, and there's 2 that have come out for obstructive sleep apnea. And I wonder if you or anybody else has come across any problems with airways with these people that have implanted devices in the neck.
Yeah, we see them quite a bit at our institution as well. Usually they're coming in for some sort of ENT procedure, so the surgeon is already pretty knowledgeable about the airway in that patient, so I haven't had any issues with that. Has anyone else had any experience?
Yeah, so one of our ENT docs obviously places them, but he educates the patients pretty well to just say at least turn off your device, if you go to surgery and that sort of thing. And I think we're kind of treating it like, if it's abdomen or whatever, it would probably be fine if it was on, but it's always best practice to kind of just turn everything off if you're able to.
Actually, interestingly enough, when I was making this presentation, I didn't realize that their recommendation is to not use electrocautery if you can, but I mean, most of our surgeons use that, so I didn't understand why that was the official guideline.
All right, so let's give a round of applause to our panel. Thank you so much.